Thanks and hello. I'm Dan Ferris with the Mick Institute for Poverty Policy and Research at New York University's Silver School of Social Work. I'm the Assistant Director for Policy and External Affairs. I'm joined today in person on the line by Yvette Kelly as well as Boris Hilgorin. And then on the line, we are so excited and grateful to be joined by Chad Shearer and Suzanne Brundage from the United Hospital Fund. We've had the pleasure of getting to work with them over these past few months after a very friendly connection was made by the New York State Health Foundation based on some of the overlapping projects and work that we've been doing. And I don't want to speak for both of our organizations, but we're pretty confident that it's a pretty solid match in terms of the goals of the organizations as well as the current work that's going on. And so a quick thank you off the top to the United Hospital Fund for joining us today and for sharing some of your work around what's happening in terms of the children's behavioral health system, children's health care, and value-based payments. So with that, I'm going to set the stage very quickly with the agenda. Also go through just a couple of housekeeping items before we jump in, and then you'll hear, if you're an attendee of today, you'll hear a collection of voices coming across. So we'll do our best to let you know who's talking when we're talking as well. But just the quick housekeeping items. Again, I'm guessing if you're joining us, you're a little familiar with the platform. If not, but just in case, we'd encourage you to chat in your questions throughout. We are leaving significant time at the end for Q&A and discussion, which we're really excited for and looking forward to. So to chat in a question, there's a chat box in the upper right-hand corner on your PC. I believe it's the lower right-hand corner if you're on a Mac. And then also the slides from today will be made available following the series. Again, this is part one of a two-part series on value-based payment for Medicaid child health services. And Chad will talk a little bit more through about the context of the series shortly. And then also just jumping into an agenda. So the context is starting with why children and why now. We'll talk about Medicaid utilization and expenditures by children. The children's health system transformation today in New York State, and to be crystal clear, that component of the presentation will be handled by the Mick Institute, and we'll be just sharing the information that's publicly available about where things stand with the managed care transition, children's home and community-based services, and state plan amendment developments. So there's no new information on the KID system transformation that's being shared today. It's all a repeat, but hopefully if this is your first time to the disco, it'll be a nice refresher for you, or possibly your first time hearing it. And that the value-based payment information that's being discussed today doesn't reflect any kind of state policy or movements in that direction. We'll then be talking about the social determinants of health. It's an area that the Mick Institute is doing quite a bit of work around. So we'll set the stage, and then Chad and Suzanne will jump back in and talk a few more specifics about how it relates to the topic of today. And then last but certainly not least, specific implications for child-serving providers. So hopefully we'll be covering a lot of information, helping to get the questions flowing. And again, just please feel free to chat those in as they come to mind throughout the presentation, and we'll collect them all and have a robust Q&A at the end. So with that, I'm going to take a deep breath and pass things over to Chad and Suzanne, if you'd like to give a quick introduction of yourselves and a little bit of context.
Great. Thanks so much, Dan. And this has been a great emerging partnership between UHF and Mick Silver, and we're so happy to be here today. I'm Chad Shearer. I'm the Vice President for Policy and the Director of the Medicaid Institute here at the United Hospital Fund. And I'm joined by Suzanne Brundage, who leads our Child Health Initiative here at UHF. And as we started to talk with Dan and the Mick Silver team about kind of what we might do on this front, given the work that we've done and the work that Mick Silver had done, we quickly realized that this was too much for one webinar. So you'll see the title of this webinar kind of setting the stage. We purposely did that. Before we can really talk about how you pay for value, it's really important to think about what does the population look like? What is the current state of services and utilization? What's happening in the transformation of the existing service delivery system for children, and where are the emerging points on the horizon in terms of where the focus on children might need to be in terms of value-based payment for children in Medicaid. So today we're really going to focus on setting that stage, but next week, next Thursday on the second webinar, we're going to dig a lot deeper into how do you measure value for children? How does that differ from measuring value for adults? And what are the different payment methodology considerations that need to be taken into account when you're thinking about what is value for children and how should we pay for it in a very complicated system with very complicated subpopulations. So just a little bit about UHF before we dig in. We are an independent nonprofit working to build a more effective healthcare system in New York. We do that through a combination of policy analysis programs, especially quality improvement programs with hospitals. We do a lot of convening of stakeholders, trying to get them around the table around tough policy issues, and then we do a small amount of grant funding as well. A big part of how we do the work we do is by focusing on vulnerable populations. And in that focus on vulnerable populations, we've worked on Medicaid issues for over a decade. And in the last 9 months, we've launched our new Children's Health Initiative and really started to focus on the intersection of healthcare and early childhood development, which Suzanne will talk about a lot later. Dan, you want to say a few words about McSilver before I continue?
Yeah, and we'll keep it brief because we want to get to the content of the day. But just to say for folks who aren't as familiar that the McSilver Institute is committed to creating new knowledge about the root causes of poverty through developing evidence-based interventions to address its consequences, and then most importantly, rapidly translating research findings into action. And we do this in a collaborative way, as evidenced by today and today's webinar, and key partnerships with other research organizations, community stakeholders and members, policymakers, and others. And I would also just say off the top that the McSilver Institute houses the Community Technical Assistance Center of New York and the Managed Care Technical Assistance Center of New York, which Yvette and I both have the joy and privilege of working together as part of. So if folks have been to a CTAC or MCTAC offering, that's very much connected to the work that McSilver is doing as well.
Great, thanks, Dan. So getting to Dan's first question, why are we focused on kids? Why now? What's happening that is allowing us to kind of think about kids in a different way? It really starts with kind of what the value-based payment conversation has been to date, and unfortunately, that has often been focused on the cost side of the value equation, and what that translates to is usually a target on high-cost, high-need individuals who are usually adults who have a lot of potentially preventable emergency department and inpatient hospital visits. And unfortunately, that means there hasn't been much conversation about children in the value-based payment context to date. So what we're thinking about is kind of why that focus on VBP for the high-cost, high-needs adults doesn't really apply to children who, and you'll hear me say this a million times, and I will beat this dead horse, children are generally a low-cost population without real immediate targets for savings, so they don't fall neatly into the existing conversation around VBP. There's also a lot of new emerging science around what really works to get kids on a healthy life trajectory. And the question is, what can we do in the healthcare system and in the Medicaid system specifically to help keep children from becoming those high-need, high-cost adults down the road? And there's a huge opportunity in New York State Medicaid right now. Dan and his team will talk more about the behavioral health transition, but in addition to that, New York Medicaid leadership is doing a lot to focus on kids. They've announced a pilot program in Albany that is focused on pediatric primary care and helping the pediatric primary care practices deliver services and refer kids to social needs resources to help them get ready for kindergarten. And in the coming months, the state will have a subcommittee that's going to focus specifically on value-based payment for children. And that subcommittee will meet throughout the fall, and it's going to make recommendations to a broader VBP work group that will hopefully inform the next version of the state's value-based payment roadmap, which is the overarching document which is designed to define how value-based payment is going to happen in New York Medicaid going forward. So as we think about the population we're talking about, we can't start to talk about value-based payment until we know who we're talking about that is the target of value-based payment. So taking a huge step back, it's always important to remember that Medicaid in New York covers 40% of children in the state, and most of those children are in a managed care plan. So over 2 million kids in any given month are in a managed care plan in New York Medicaid. Those that are not in managed care are really not part of the immediate VBP conversation. The goals of the value-based payment roadmap are to get 80 to 90% of managed care payments from the plans to providers into value-based payment arrangements by 2020. So while we're not talking about those populations that aren't yet in managed care, as many of you on the phone I'm sure know, the state really does intend in the future to carve all children into managed care, even children with developmental disabilities. So in the long run, we will be talking about all children, but it's important to remember at this point we're not talking about VBP for those children that aren't yet in a managed care plan. So as we think about VBP for kids, it's also important to remember that children at different developmental stages have different needs. So one of the first things that we do when we start to look at the population of children is do an age breakdown of kids so that we can see kind of who's in the program at what age, and then as we talk more about the data, we always try and keep that age breakdown in mind so that we can think about the different needs of kids at different ages. So what are the data needs as we start to think about how we pay for value in Medicaid for children? What we really want to do is think about what data is necessary to make thoughtful decisions about that value equation. And again, it's important to remember that children are not like adults, and for any of these data elements, it can be important to assess the difference between children and adults when you're thinking about the payment structure because you need to change the payment based on the unique needs of children. And then everything else in the data that's necessary really falls into the category of how do you slice and dice the underlying population? How do you segment it into its component parts to understand where's the variation that we need to target? How do we get to promoting the best utilization of services, increasing where there's underutilization and decreasing when there's overutilization? And what we generally do from an analytic perspective here at the Medicaid Institute is start with a broad look at both overall utilization and expenditures, and then dig deeper looking at the demographics of the population. The problem with demographics is you're often limited by what's available in claims data and even in electronic medical records. So you're often just dealing with age, race, and ethnicity and geography, and you don't have a lot more demographic information right now. Then we look at the type of utilization. Where are the different types of services happening? What kids are using different types of services? And then we dig on diagnoses. What are the conditions that drive service utilization, and how does service utilization vary kind of based on demographics, based on utilization type, based on diagnoses, and crossing those elements as much as possible to get a clear view of what services kids are providing, where the variation is, where we may need to target more services, where we may be able to reduce some overutilization of services where that might happen. So in practice, how does this play out? We did a very detailed brief and chart book over the summer, which really looked at the whole of service utilization and expenditures for kids in New York Medicaid. We started by segmenting the population by total expenditures, and we quickly found out that we're really talking about two groups of kids. You've got the 90% of kids that don't cost a lot and don't have a lot of need, and then you've got that small 10% of kids that make up approximately 50% of all expenditures. And that small 10% group of kids is an extremely complicated population. It includes children with a range of conditions, which may, as we think about how does the delivery system and the payment system deal with a very heterogeneous population of high-need kids. It's also important to note that when you're talking about that 10% high-need population, that there is a significant level of regression to the mean in that population, and by that I mean that the kids that end up in this 10% category in a particular year may not necessarily be in that 10% category the following year. So that's something to consider anytime you're cutting this data and thinking about overall utilization for children. So as we dig in on the utilization a little bit deeper, we look at utilization by type. And on the bar graph here, you'll see emergency department and inpatient hospitalizations for children by age group. And I'll note here, it's important to look, and it's hard to see on this slide, but you'll be able to see it in the printout, that the scale on the two sides of this bar graph are actually different. So the scale for emergency departments is on the left side, the scale for inpatient is on the right side. But it's not the specific numbers here that are important in this graph. It's really the curve that we're looking at that is important. And what that curve shows is that utilization generally in total is higher in the early years, decreases down to about age 10, and then really starts to pick up again. So when we see something like that in the data, then we dive deeper and say, okay, what's driving that? So we look at the diagnoses. And for the younger children, a lot of that diagnosis-driven utilization is based on asthma and gastroenteritis. And in some cases, you know, those may be avoidable utilization, so that's something that deserves a deeper dive. In the teen years, most of that hospital utilization is driven by behavioral health conditions. So that's another area where it says, okay, here's where the utilization is. We should focus on that subpopulation or that particular set of diagnoses. So it's not presented here, but if we showed you overall expenditures, it would follow a very similar curve by age. But when you just look at managed care expenditures, that effectively flattens out the curve because managed care pays one rate for children regardless of what they use, and what you see in the non-managed care expenditures is all those high-need populations that are currently still carved out of managed care, or say the BH services that are carved out of managed care. Important to note here that this curve does not necessarily work for primary care. So while we didn't put this slide in, primary care is very high in the early years and decreases slightly with age. But overall, we find that primary care utilization in the children's population in New York Medicaid is fairly high. And you know, access to primary care when we compare New York to other states nationally is fairly good. So when you're thinking about primary care, utilization is actually fairly strong in New York Medicaid. So here I am again, beating the dead horse, but when you look at utilization and expenditures for children, it is extremely different than similar utilization and expenditures for adults. Kids have fewer inpatient and emergency department visits, and they have more primary care visits than adults. And net, what that really nets out to is that kids are a substantially cheaper population than adults to serve. And not surprisingly, a lot of this difference is driven by kind of the lack of major chronic condition diagnoses in children. So adults have a lot of inpatient and ED visits for COPD and CHF. You just don't see that utilization in kids, which is, another reason why the delivery system and the payment system probably needs to differ a little bit when we're talking about children. So take all this data together, and what does it mean as we think about moving towards value-based payment for children? First and foremost, it suggests that we don't have a lot of avoidable hospitalizations that have been the historic target of adult-focused VBP programs. So if we're looking for savings to reinvest in other children's services, we may have to look somewhere else than the kids' services themselves. The data also suggests that somewhere along the way, we probably aren't doing the best job of preventing some children from becoming high need in the future, whether that means becoming high need adolescents with substantial behavioral health needs or becoming high need, high cost adults down the road. And I think that suggests to us a need to both rethink the services that we're providing to kids, but especially how those services are reimbursed going forward to focus more on preventing kids from becoming high-need, high-cost Medicaid populations down the road. And as we think about the 90% and the 10%, the well kids versus the high-need, high-cost kids, we think the data shows that you have to treat those subpopulations differently, both in the way that you provide services to them and the way that you pay for those services. And, if you do a system focused just on the high-cost, high-need kids, that system probably isn't going to work for your well kids. So we need to think separately about those populations and think about the value-based payment approaches for those populations differently, and we'll talk a lot more about that in Webinar 2 next week. So, of course, the kids population with behavioral health needs is one of those higher needs subpopulations, as we find from our data, and has really rightly been a focus in New York Medicaid of late. But before we think about VBP for that subpopulation, I think it's really important to understand how the services and delivery system for that population are being transformed. So I'll turn it over to Yvette and Dan and the team to talk more about the system transformation.
Oh, thank you very much, Pat, and thank you for that very important context as we think about the changes that are happening in the children's system. And for all the attendees on the line, I just want to quickly introduce myself. My name is Yvette Kelly, and I'm with the Mick Institute. And I'm just going to spend a few minutes talking with you about some of the changes that are happening in the children's health system delivery today. And again, as Dan mentioned, some of you may have heard this or may be aware of this, and really this is just an overview of some of the changes, and none of the information presented on this webinar is new, but really just to, again, orient the listeners. And so I'm going to start with one of the biggest changes, which is the transition of the children's services to Medicaid managed care. And I think in understanding why this is happening, it's important to understand what are the goals behind this change to managed care. And I think the significance of this change is sometimes not well understood. And with children being enrolled from the fee-for-service to managed care, it's important to understand the overall goals of why this is happening. And that is really to have better health, better care, greater access, and lower costs. And so providers who are serving the Medicaid-enrolled children will be expected to contract with managed care organizations and will bill them for the services provided. And the MCO will receive a monthly premium from the state to manage an individual's care and benefit package. This transition is expected to take place July 1st of 2017 for New York City, Long Island, and Westchester, and then for the rest of the state, January 1st, 2018. Another transition that's happening in this process is that Children's Health Home is starting December 1st this year. They will begin statewide. And Health Homes is an entity that provides care management to children with complex needs to ensure coordinated and comprehensive planning that is family and youth-driven, supports a system of care that builds upon the strengths of the family. And so both these initiatives really work together to integrate to the delivery of physical and behavioral health services identify and address needs early to prevent escalation and longer-term need for higher-end services. And you heard Chad speak a little bit about that when he talked about the implications in some of his data and the need to really begin to identify these needs early on to prevent longer-term services and higher-end services. So that's kind of how the system is really trying to align to really meet the needs of children. The Medicaid plan has proposed 6 new state plan services to be available to all Medicaid-eligible children under the age of 21 who meet medical necessity criteria. And these services are often referred to as SPA services. And the intent of these services are to improve the service system's capacity to identify the needs early, to maintain children in their natural homes and communities, again, to prevent the need for more expensive long-term services, to support the use of evidence-based approaches, and to follow trauma-informed principles. These services include crisis intervention, other licensed practitioner, community psychiatric supports and treatment, psychosocial rehab, family and peer supports, and youth peer supports. For more detailed information regarding these specific service types, please visit ctacny.org for more information. We actually did a whole series with the state that really outlined the components of each of these services. So if you want more information on the specifics, I'm going to recommend that you go there. But these are services that are expected to be implemented statewide on January 1st, 2017. The other benefit that children will have in this new system is the home and community-based services, which is designed to offer support and services to children in non-institutionalized settings, again, allowing them to remain at home. And these services are intended to be person-centered, recovery-oriented, integrated, data-driven, trauma-informed, flexible, and mobile. And again, the intent of them is to prevent the need for the child to be placed out of the home, to be able to bring the service to the families and children that need them. Again, the expectation is that this service will be rolled out July 1st of 2017 for New York City, Long Island, and Westchester, and then again January 1st, 2018 for the rest of the state. Now, the children's system currently has this service. I think the difference is that all of the services that are available under a variety of waivers will be aligned under one umbrella so that the services will be available to a broader array of children. So SPA versus home and community-based services, what's the difference? This is a question that we often get. The question is often, how do you know if a child is eligible for SPA services or home and community-based services? And so this is really just a summary slide to kind of point out some of the differences. The state plan services are intended to be available to a larger population, again, really trying to be more preventative in nature and to provide care in order to prevent further escalation of behaviors. So really trying to see them on the front end to provide more services to families in their home settings prior to meeting the level of care that would require home and community-based services. And so knowing that the service is a bit more limited, so there's limits on eligibility, and it's determined by the results of a CANS New York assessment. It's rehabilitative and habilitative in nature, and it is for those kids who require a higher level of care. All right, so these are probably the kids who would maybe traditionally be referred for an out-of-home placement or a higher level of care. And so that's the difference between SPA and home and community-based services. And so let's talk about some of the next opportunities and looking at that. And really, I think framing this, I think there's lots of opportunities in some of the information that's going to be presented today and what we know, and as well as looking at the social determinants of health and pediatric primary care and what we have come to learn about how this plays out in terms of helping the system and helping kind of providers really work to determine what we can do for the benefits of children and families. So we talk about social determinants. These are the health conditions in which people are born, grow, live, and work. And really, it's just a wider set of forces and systems that shape the conditions of daily life. And so when we think about this, these are the factors that impact upon health and well-being. And again, these are the circumstances into which we are born and we grow and we live and we work upon. And so we know that these factors are generally shaped by the distribution of money, power, and resources at the global, national, and local levels, which are in themselves influenced by other policy choices. And so when we think about the social determinants of health and the impact that this has on the overall well-being of children and families, one thing that we look at here at McSilver is really the impact that poverty has on all of these factors. And we see poverty as kind of that underlying issue that really kind of speaks to some of those other social determinants. We know that poverty has been associated with numerous mental health outcomes and has led to a number of issues related to adverse early childhood experiences, which influences health and well-being throughout the lifespan. So it would be within our best interest to really begin to attend to some of these in the provider world and think about how in our role in working with families and children, how we begin to attend and address the issues of social determinants of health. And so what can we do? What can we do as providers? And so one of the first things we need to be able to do is be able to assess for the social determinants of health. There's a lot of times where we hear that providers don't necessarily ask those questions because they're unsure about how they can address an issue as it relates to housing or in some other realm that they don't feel that they necessarily have control over. But really being able to assess this and link our children and families to the needed resources that are available, understanding that there are some service gaps and some shortages is going to be very important. We need to build staff and client knowledge. So we need to inform not just our staff, but our clients as well in terms of the impact that this has on health. We need to sit back and address our own personal biases and how we look at situations and how we categorize people and how we perceive their problems and issues, and really think about that from the standpoint of a helping relationship. We need to build community-based partnerships, so we need to be, again, linking to those other resources who could be helpful in really in helping our service delivery for a family so that they can overcome some of the stressors that they're experiencing and situate themselves in a better place. And also, we need to engage stakeholders outside of health. So if we're thinking about all the transformation that's happening in the system, the intent is to integrate, to look at whole health. So not to silo off these systems, but really to build kind of a network of support around children and families who struggle with a variety of issues, some that is not of their own choosing. And so as we think about this and think about the impact that has on health, I think it's going to be important that we begin to build our knowledge and our expertise in this area. And so with that, I'm going to now pass it off to Suzanne to talk more with you about kind of the overview of science and some of the other data that they found related to this. Thank you.
Thanks, Yvette, for that great setup. So what I plan on doing in the next 6 slides is talk about social determinants of health in the context of one of the defining features of child health, which is child development, particularly early childhood development. It's our perspective that any value-based payment approach for child health services has to be informed by this distinct characteristic of child health. It is one of the things that makes it so unique from adult health. And this is particularly an important topic for the Medicaid program. We're going back to the heart of the formation of the EPSDT. The goal of child health services has been the attainment of maximum health potential for children, not just the treatment of disease. This is a very core fundamental part of what EPSDT was created to do. So now starting to think about that in a value-based payment arrangement is particularly important, and we suspect it will be one of the issues that will come to the forefront as New York Medicaid's program has their subcommittee on children and value-based payment services. So very quickly on early childhood development, first, it's important to recognize that child health epidemiology has changed significantly over the past few decades. Infectious disease, as we know, thanks to vaccines, have really been on the decline. There's been a marked increase in chronic disease and behavioral health issues. And notably, most of the major health threats that children face today are developmental in nature. And what that means is it's the cumulative effect of multiple threats to health over time that results in poor health outcomes. And there is broad consensus, broad scientific consensus, that early childhood experiences play a significant role in shaping long-term health, learning, and behavioral outcomes. I think most people are probably pretty familiar with this science. And what's been particularly extraordinary about that science is it's enabled us to have a better understanding of how early experiences are connected to long-term outcomes, really the precise mechanisms by which a child's brain continues to grow after birth. And one of the main findings from that is the active ingredient in brain development is safe, stable, positive interactions with adults, primarily parents and caregivers. What this all means is that children, particularly young children, are disproportionately sensitive to the influences of their social and physical environment. And I'll admit here, I think the terminology starts to get fuzzy. Some people talk about social determinants of health, some say social determinants of early childhood development. Others have started to adopt adverse childhood experiences as their preferred umbrella term. Regardless, I think all of it points to some of the same fundamental conclusions. One is the family is the primary environmental influence on child's development. So the family provides the main stimuli, and they also mediate a child's interaction with the rest of the world. And really what this means is it becomes very difficult to separate child health and well-being from a family's health and well-being. And you can kind of see how that's true under this foundations of healthy development, that's kind of the bedrock of what it takes to set a child on a good developmental course. Second is child development, healthy child development is a balancing act between the risks or negative forces that can hinder healthy development and the positive forces in a child's life that promote healthy development. And together what that means is children living in poverty as a group are particularly important in this discussion because children in poverty tend to be exposed to more threats to healthy development and less likely to be exposed to the protective health or those factors that promote healthy development than their more affluent peers. And we've all heard a lot about the impact of poverty and early adversity on healthcare utilization and long-term health. That can happen. Those outcomes are kind of linked to early experiences through the disruption of developmental processes during sensitive periods of growth, or through cumulative exposure to threats which literally results in sort of a wear and tear phenomenon on physiological systems. It's very akin to early aging. Additionally, to the extent that social determinants of health result in a parent having less time to interact positively with their child, keeping in mind that is the actual active ingredient for healthy development, social determinants of health can interfere with the parent-child interaction. And the results of this, the impact is not just on the healthcare system, it has implications for educational and social outcomes too. The challenge here is, so that makes it more profound and more important. I think it also makes it more challenging to deal with within a single system or to place it neatly within value-based payment. And we'll get to those challenges, particularly in the next webinar, a little bit today. So the good news is that evidence is quite strong and growing that early childhood interventions can improve lifelong health. I'll return to these categories on the left. There's some of the main ways in which early childhood interventions, the types of interventions that are out there to put a child on a healthy trajectory. And at the core here, and this is where we really get back to healthcare services, an untapped strategy for thinking about early childhood development promotion is strengthening pediatric primary care. I borrowed this graph here from Rahil Griggs at Montefiore, and what I like about it is it expresses the sense that, formal systemic opportunities to influence child health and development change over the course of childhood. So if you look at the far left of the slide at the 0 to 3 years, it's important to think about this in the context of how much we have achieved, particularly New York State has achieved in the last few decades, with nearly universal health coverage for children in New York now, and with most of those kids and families making frequent visits to well child care in the first few years of life, pediatric primary care has this enormous opportunity to do a bit more to influence lifelong health by combining, we think, by combining the traditional health visit, the well child visit, with primary care-based approaches to identifying and responding to social determinants of health and providing some interventions that positively promote healthy development. So we published in January a paper that categorized 6 different approaches to promoting healthy childhood development that are based out of pediatric practices here in New York. I'll note this isn't an endorsement of a singular approach or model. I actually think it's better to sort of think about these as a set of capacities that could be built into child-serving primary care to generate additional value from the system. And I'll draw your attention to the first category, which is screening for social determinants of health and helping families connect to needed services. Earlier this month, JAMA Pediatrics published the first ever randomized control trial on a pediatric social needs screening and navigation program. This was a study that was run out of Oakland, and it basically compared the effect of screening children for social needs in pediatric primary care and placing them in a social needs navigation program that was run out of practice versus sort of standard care. In their case, they handed families, a written referral to social services. In most cases, probably that doesn't even happen. And what the study found was that at 4 months after enrollment, basically after the study started, those kids and families that received the screen and navigation program had significantly decreased reports of social needs and significantly improved children's overall health status as reported by caregivers. That was within 4-month period. And so this research is, it's interesting to me because it's very consistent with a strong push from the American Academy of Pediatrics itself to incorporate social needs screening into routine primary care practice. In October 2015, the Academy called for universal food insecurity screening. In March 2016, in a statement about poverty in children's health, It called for broader social determinants of health screening and the incorporation of parent support programs into the medical home. So one of our key questions I think in children's health today is how to align this momentum and these growing innovations in pediatric primary care with a value-based payment framework. We're going to dig deeper into these challenges next week, but I want to tee up a few of the big issues here. One is early childhood interventions can provide better health outcomes. The science is pretty solid there. But these outcomes often don't become apparent for several years, and the averted costs don't happen in a single-year budget window, and they often accrue to multiple systems, not just Medicaid. So you combine that with the data Chad presented earlier about children being a low-cost population in general, and it is probable that additional investment in early childhood, perhaps in the form of a social risk adjustment, would be necessary to generate the desired health outcomes from the system. Two, there are important questions of whether it's possible to hold providers accountable for social determinants of health screenings, interventions, or outcomes. Really need to think about what is in the clinician's realm of influence, whether joint accountability across systems is needed, and we will certainly touch on those next week as well, some of those questions. And then third, there's no doubt, significant delivery system challenges to scaling and sustaining any new expectations placed on pediatric primary care. And, there are lessons, of course, from the adult primary care transformation world around technical assistance, provider training, giving providers, additional education to make them comfortable with new subject matter. But there's a whole kind of series of things to think about if any of these innovations are to reach scale and spread. So with that, I'll just leave you with this quote from Michael Bailett and his team at Bailett Health. UHF, together with the Schuyler Center for Analysis and Advocacy, published a paper this summer on value-based payment for children's health services. And what this quote really points to is the core of what we're going to talk about in next week's webinar. It's the need for sort of the nuts and bolts of measuring and paying for value in children's health that takes into account the social determinants of health. And with that, I think we'd be delighted to open things up for questions. Chad and I have provided our contact information here and a set of publications from UHF. I know Dan and Yvette also have a number of resources for folks.
Great. Thanks so much for a fantastic presentation and walkthrough to Chad, Suzanne, and Yvette. And so we're just going to take a quick second and just talk about a couple of resources that are available. So up front from the United Hospital Fund are the reports that they talked about on today's presentation. Also here is a really fantastic resource through New York State. It's the Value-Based Payment Roadmap, and the Department of Health has a landing page for general resources and information tied to value-based payment and the state's movement towards value-based payment more broadly. So be sure to check that out if you haven't already. Also, I'd encourage everyone to tweet Chad and Suzanne as their Twitter handles are here on the left. Also, on the McSilver Institute side and the technical assistance side, as Yvette was mentioning, over the summer, we hosted a series on the individual SPA services for children's providers, and that followed an in-person series on children's system transformation in New York. All of those resources are available on the CTAC website, which is ctacny.org, and we have specific links here on the page. And then we'd also encourage folks, as they have questions, both about value-based payment and other components of the children's system transformation, to email them to ctac.info@nyu.edu. We also know, which is the other advantage of having a two-part webinar series, that, as soon as you get off the webinar today, you'll have 3 questions come to mind about value-based payment. So we'll also be using that address to collect questions, any feedback or comments or areas that you'd like to see addressed in the next week's presentation, part 2 of the 2-part series, which is taking place next Thursday. So if you haven't yet had a chance to register and you like what you heard here today, we'd encourage you to sign up and join us next Thursday as well. Great, and with that, we are going to move into Q&A. So as we mentioned at the top of the webinar, the chat functionality on the WebEx platform is in the upper right-hand corner and possibly the bottom right-hand corner, depending what browser you're using. But if you click on the chat icon, it should open a chat box. We just ask that as you're sending the question in, that you please send it to all panelists, which is one of the options on the drop-down. So we'll give folks just a minute to think through their questions. There's a lot of information to get through today, and so again, we'll be back with everybody next Thursday. So if things come to mind after we wrap up today, don't fear. You can send them to us in an email, and then also join us next week. All right, great. We've had a couple of questions come in already, so we'll just take these easy ones off the top, as I'm sure some of the more complicated Stump Boris, Chad, Suzanne, Dan, and Yvette questions come through. So will these webinars be available for printing? And then we would just say absolutely. The webinar slides will be posted onto the CTAC and McSilver websites as a reference. And then we'll also send these around to folks probably after the series concludes, for both a copy of the slides and then also recordings of the webinars in case you would like to revisit the description of the children's system transformation or one of the great reports that UHF has pulled together. So another couple of things that have come through and a couple of comments that we'll actually share. And again, just if folks can please send these to all panelists on the drop-down, it's really helpful as we're located in 2 different geographic places, thanks to modern technology for letting us do a Q&A from multiple locations. But for Chad and Suzanne, we had a couple of folks asking for the links to the papers and then the citation for the paper that was mentioned that was done in collaboration with Baylor. So I have us open to the resources page if you guys just wanted to do a quick reminder of just what specifically and where the resources and reports that were talked about are available.
Yes, so the Baylor paper is the 3rd paper on here, Value-Based Payment Models for Medicaid Child Health Services. And then Suzanne worked on a paper that came out about the same time, which gets to the measurement as well. So that's the one above that. And then all the data that I presented came from the Understanding Medicaid Utilization for Children paper and associated chart book.
Great. And Chad, I believe a comment/compliment and then also a question for you. Somebody just commented how well they took the point about preventing children from becoming high needs. And then the question being, will this, being value-based payment, affect APG rates that providers get now?
I think it's possible that down the road APG rates would change. The way we've been thinking about this is that would there be a kind of social determinants risk adjustment that would be applied to kind of the base APG rate that would account for the true need of the child, taking social determinants into account. There are other ways that you could go about thinking about adjusting the APG rates, but I think we think that that social needs risk adjustment may be the most, well, the easiest and the most reflective of the actual needs of the children and the resources necessary to care for these children. But there are myriad ways that we could think about changing APG rates.
Great, thanks. And we've gotten a couple of other really good questions come in, so we'll just keep sending them your way if that's okay. Perfect. So one is an opinion question. So do you think that VBP is set up to really take on and think about and fund prevention work?
So I think, that's a complicated question to answer. I mean, what we see, so first of all, value-based payment is an umbrella term for a lot of different payment methodologies and ways of setting up value-based payments. Obviously, the predominant models that are out there today take a baseline expenditure at the beginning of the year, compare your expenditures at the end of the year, and whether you had quality, you met some sort of quality threshold at the end of the year, and that's the basis on whether you get service, savings. At least that's the kind of Medicare ACO MSSP model. And so it's our opinion that that precise model of VBP probably doesn't work well for the overall children's population, given what Chad mentioned. But we think that the idea and the core value, excuse the pun, values within, value-based payment are pretty consistent with the overall goals of doing long-term prevention in children's health. It's just you have to kind of think about a longer time frame is one of the key components, and the more you can capture either savings or positive outcomes across systems, ideally at a minimum between healthcare and education, and becomes more feasible to do. But for sure, this is cutting edge, and as usual, New York would be leading much of the country if it went down this path.
And just to kind of give a preview of next time, we will talk a little bit about potentially two different payment models for the well kids population, which really does focus on prevention, and we'll talk about how we see prevention playing into that model, and then a different model for that kind of 10% high-cost population, which really isn't focused on prevention. It's really focused on meeting the chronic needs of that high-cost population.
Great. And here's a question that we've gotten a few times along the way as well. So it'll be really interesting to hear both of your takes on this. So what happens in other places, or even theoretically, if a provider does everything that they can and all resources are supplied to a family or a client, and their goals aren't met, and that they don't get better, for lack of better words? What happens with payments then if it's tied to people's recovery or getting better?
Well, I think when we think about payment, we're talking about systems, and we're talking about in the aggregate. You will always have outliers, and but in the aggregate, that one family that doesn't meet their goals is not going to throw you off from the whole of your population if you're doing kind of a population health improvement approach to preventive primary care. But maybe a bigger issue when you start to think about risk adjustment for the more complex population, and whether kind of the payment for those more complex populations truly reflects the amount of resource necessary to deal with those people that are probably maybe never going to hit their targets through no fault of the provider and the system of supports around those patients. So I think it's complicated, but I think in the aggregate, you're going to have those outliers on both sides in terms of resource utilization and how well people are doing vis-a-vis the goals. And I think in general, we think it all averages out, but it's definitely a consideration in the higher cost population to think about how that plays out.
Great. So looking on towards the next question. How can behavioral health clinics that serve children prepare for value-based payment? And then is value-based payment primarily mediated by the managed care companies?
I think the most important thing that behavioral health providers can do is kind of understand who they're going to be working with going forward in this bigger system of, value-based care. So you're going to be working either with a pediatrician for most cases, or with an integrated delivery system in a hospital, and understanding kind of how you're going to interact in that system. Now, for the subspecialty BH, I think this question is unanswerable at this point. We don't even have the BH services in managed care yet, so I think it's a little bit too early to suggest, how specialty behavioral health providers are going to enter value-based payment, when it's going to happen, exactly how it's going to happen. But as you think about preparation, you can always benefit from having a deep understanding of the population that you serve, and that means understanding not just your own claims information and the services that you're providing, but to the extent possible, understanding the whole of what your population looks like, not just on the behavioral health service side, but on the physical health service side as well. So thinking about that population segmentation universally, as I talked about that. And I think just kind of core capacities to do this include data capacity generally, registries and being able to track your patients on a daily basis or a monthly basis, or so that you can do continuous quality improvement. And then kind of what does your internal workflow look like, and thinking about how that might need to change, if you're doing more on kind of not just the behavioral health condition, but also you're charged with doing something on a specific social determinant, or connecting your members with other resources that may take, workflow changes, workforce changes. So starting to look at where you've got gaps and address that. And I would say that Mick Silver and the MCTAC have been great resources for helping providers think about, okay, what do I need to do to get ready? So Dan, you probably should answer that question.
Right. So thank you, Chad. So just kind of, to add, because I think you hit it on the nail here in regards to this, but I think providers, and I would actually say behavioral health or others, again, I think they need to start thinking more in a sense of being part of the healthcare landscape, where they fit in it, how they work with other providers and other healthcare organizations. And I think, as you pointed out also, this is more about population health. When you talk about value-based, of course, you want to take care of the individual and the family in front of you, but the way value-based is structured is it pushes, almost forces, I would argue, providers to work together under some sort of either be an umbrella or some sort of relationship, and at the same time looking at all of those individuals they serve together. So I just wanted to, is that a fair kind of a statement? Would you agree with that? And again, I want to, sometimes we get caught up between behavioral health and primary care, but I think it's probably applicable to all healthcare providers as we move to value-based.
Great, and thanks to everyone for sending in these really terrific questions. We're gonna take a few more before we wrap things up for today. And then if we don't happen to get to your question before the end, or if it got lost in the shuffle somehow, please do send us an email with that question, ctac.info@nyu.edu. If something comes to mind after the presentation, again, you can email us and we'll fold it into the content that we're hoping to cover for next week. So one question is, has there been any thoughts or planning for this becoming a deterrent for providers to take on new patients that come along with value-based payment?
Our take, and we talk to pediatric providers mostly, so this may be different than kind of how the behavioral health providers see this. Our take is that the pediatric providers really want to do what's right for this population. They feel like historically they have been under-resourced and that the payment system has not recognized the value that they already provide, and that they see this as a huge opportunity to, do better population health with their child members. So from the primary care side, I don't think we think that's going to be an issue. I think there may be other providers that are worried about taking on the complexity of VBP. I think you can be engaged in VBP without taking on risk, and I think that's where a lot of providers get confused. They say, well, I can't afford to take on risk, so I'm not going to engage in VBP. You don't necessarily have to take on risk to engage in a lot of these models, and we'll get into that a lot more next week as we talk about kind of the difference between the models that Bailey laid out in our paper and kind of the models that exist right now in the New York State roadmap, and trying to think about where's the right place to put this kids VBP kind of in the middle of those lanes.
Fantastic, and that's a great segue actually, talking about spoiler alerts for next week and what we'll be covering. We had a question come in asking if UHF has looked at VBP for children with medical complexity, and that it's a subpopulation that folks are presently trying to define measures for, and how and will this population be featured next week or in future work collaborations?
So we've done a number of things on this front in our data work, and I didn't present any of that here. We looked at a subset of children with complex chronic conditions, the CCCs, which were developed by ARC, I believe, as kind of our proxy. And then the Bailiff paper talks about kind of kids with medical complexity. There are a lot of different definitions: children with special healthcare needs, CCCs, medical complexity. Each of them kind of has their own methodology in terms of how they define that population. Generally, we're talking about the same kids that fall into that 10% category that I talked about. We will talk next week about a payment model designed specifically, effectively for the medically complex population. But measurement and definition for that population is very difficult and very different than the payment model that we'll talk about for the well kids next week. And Suzanne, I know you've done a little bit thinking about kind of how you define this population and measurement for this population and how it differs.
Yeah, I would just add for the person that asked this question, in the You Get What You Pay For Measuring Quality and Value-Based Payment paper that's on our resource list, there are 3 case studies in there. One of the case studies is of Nationwide Children's Hospital in Ohio, which has about 300,000 Medicaid children attributed to it, and it's in a full risk value-based payment arrangement with the 5 Medicaid managed care plans serving that part of Ohio. And just as this person asked, I think they've been looking at CHOP, Children's Hospital Philadelphia's work. Nationwide Children's is also a children's hospital. Most of the work that's been done around value-based payment for medical complex kids really is being driven out of the major children's hospitals. I raise that because I think it poses some interesting questions in New York, where a lot of children are served in institutions hospital systems that serve both adults and children. But anyway, looking at what Nationwide Children's Hospital has done might yield some interesting ideas for quality measures.
So one thing, apologies, we're just kind of looking through some of the questions that have come through. So another great question that I think is very relevant to the reports that have been discussed and some of the conversation we've already had are there models in other states that could inform New York's work around VBP?
Yeah, there are a few models in different states. Again, in that same report that I just mentioned, You Get What You Pay For, we took a look at Oregon and their CCOs. So Oregon has created these coordinated care organizations, which are done on a geographic basis, but they actually had a legislative mandate to think about kids in the context of VBP and also think about trying to preserve long-term prevention programs for kids in a value-based payment. So it's a very interesting example, particularly for the kinds of quality measures that they currently use focused on children. You know, right now and in the upcoming years, they have their recommended measures listed online. But they also, there's great information about some work being done to create a kindergarten readiness measure. It's actually a bundle of measures partially driven by basically pediatric primary care and partially driven by the early education system. So that's a good example. You know, there are other examples out there of bundling for specific child health conditions. Asthma has had a number of bundle pilots as well that people could look at.
But in general, I would just say that as we worked on both our measures paper and the work with Baylor Health, we didn't find a lot of, you know, easily replicable programs in other states that we could steal from. I really believe that New York Medicaid is on the vanguard here, and that's why this is, you know, tough new work that we're going to really have to clear a new path on, because there's not a lot to look at other states. There are some unique specific lessons on specific measures, et cetera, but no kind of clear, this is how you do VBP for kids. This is why we think this is a great time to be, you know, leveraging this opportunity that the state is providing by focusing on this population.
Yeah, we'd agree. It's an exciting time, and we're looking forward to continuing to work on this front, to be sure. So with that, we are at 3:45, and as studies and statistics show, after about an hour and 15 minutes, tends to be folks' attention capacity for web-based offerings. So we're going to cut things off for today. Next week, on September 29th, again at 2:30, we'll have part 2 of the 2-part series, Measuring Value in Children's Healthcare. The description is available in the e-announcement, and then also we got a couple of notes of folks wondering where to sign up for this. So at the risk of my colleague Morgan McGuire, who's doing the tech stuff on the back end for today, thank you, Morgan, throwing something over the cubicle wall at me, maybe we will actually send out the link for folks from today to register, just in case you haven't had the chance, as well as the slides and the recording when it's available. So folks, we're really looking forward to continuing the conversation. Thank you so much to Chad and Suzanne for really incredible presentations and sharing their work and perspectives with us, as well to Yvette and Boris on our end for chiming in along the way. So thanks to all, and we'll be back with you next Thursday, 2:30, same place. All right, thanks so much.
Thanks, Dan.